That's perfect. You drill, baby drill, I think is the actual...
Sorry, that mouse is actually not moved anything.
Do you have to do it on this computer?
If you don't mind.
Okay.
Do I run it over there? Or... I might log into my drive. Yeah, that's right.
I'll log you down.
That's fine. Just ignore the the vast folders of porn.
Does critical care applications?
Yeah, it's weird. I even put parentheses on mine. I don't understand why I did that. This is our solution to the fact that we're being sent out to hack it. And the applicants are going to be all over there, and we're going to be over in MS-169. It's actually really kind of interesting to try to say, well, we invite you on lecture day.
We're webcasting.
We're webcasting. We are in the future. Anyway, I'm going to be watching my office. No, I'm kidding.
See ya!
I think Maney's actually watching. I gave him the stream until I asked him to see how well it worked. We're not on the same network.
Let's see here. Come on, Sepsis.
We're on Sepsis 3.1 at this point?
No, that's my abbreviated thing to do. Oh no, it's 50 megs. Sorry, I'm gonna use your entire...
Yeah, that's alright. I decided I got tired of this Linux distro and I'm gonna put a new one in. Because that's my hobby these days. I have nothing left at this point.
Have you considered suicide?
It seems like it only works once. You can hit F5 to start.
Ta-da!
Those are awesome.
Da!
Those are so awesome.
My title went away. I blame you and your Ubuntu.
I'm sorry.
Hope all my... Okay, guys. Hello, welcome. Sorry I'm late. I had junior faculty development program class, so thank you for coming and listening to me blather on. I work the overnight at Malta. If I curse a lot, I apologize. Sorry to anybody watching this as a webcast. Looking directly at the camera. Okay, so I'm going to talk to you today about Sepsis 3.0, and kind of, unfortunately, it's going to be a little bit literature heavy. What I'm going to do is walk you through the past, probably about 20 years of sepsis literature, and how the hell to treat people with sepsis, okay? Everybody tracking? I use these pictures because they're really kind of fun. Sepsis is not kind of a new thing. It's been around for quite some time. These are posters from World War II. I really like this one, because I like to think of sepsis as some little weird Nazi guy. So, anybody give me an idea what sepsis is? What is it? Anyone?
It's an infection with signs of end organ damage.
Yeah. What was that, Casey?
Someone's trying to change my understanding of religion.
Great. You know what you didn't say? And thank you for not saying it. Surge criteria. Thank you for not saying that. Up until last year, I expected everyone to say surge criteria plus source of infection. That's what sepsis is. And thankfully, I've apparently broken you all at some point. Or not broken you enough yet. Anyway. So it's not kind of this new thing that really the first time the word sepsis was used was in the Iliad. That's the first time it was written down on paper. It is from the Greek verb sepo, which means I rot. And the source of it is kind of this story about this guy named Hector, who's one of the heroes of the Iliad, where he gets killed and he gets taken into the believe the Trojan camp, and the body sits there and it doesn't rot. And his dad Priam goes in, asks for his body back. Then they go and they do all the Greek burial stuff, and yay, he died heroically in battle. Greek people like that or something. Anyway, that's the first concept. So, who's this guy?
Hippocrates.
Yes. So Hippocrates, he liked to talk a lot about sepsis, and Greek medicine was really weird. It talked about the humors, the different bodily fluids, this balance between sepsis, which is rotting, decaying, and pepsis, which is digestion and kind of a positive process, and a balance between those two things. That's enough about that. There's a whole lot of things that it's much more complex than that, but Greg, your thing is screwing up all my slides, dude.
Sorry.
I'm gonna cut you.
I told Noah we need a real computer.
Yes. So that was kind of the end of the advances in medicine, because there was this thing called the Dark Ages, and science didn't really exist. So up until the kind of late 1800s or late 1900s, when the germ theory of disease was created, it was kind of like, well, this person's sick. Let's bleed them to death. That sounds like a good idea. Let's give them this poultice or this magical elixir or potion or something other magical. And up until medicine was kind of formalized, it was viewed as like quackery. And actually, one of the cool things about allopathic medicine is it was the, up until about the 20s and 30s, it was viewed as complete quackery. So, really interesting. Anybody knew who William Osler was? Famous doctor, yes. You get to pass. So he had this nice quote, said, advances in the treatment of fever have not kept pace with the rapid progress of our knowledge of the etiology. Talking about the germ theory of disease, talking about understanding bacterial infection as the cause of illness and the cause of fever. In the present condition of bacteriology, we may expect great things in the near future, but meanwhile we jog along without any fixed aim, too often swayed by the winds of doctrines and wild theories, is what that says behind the picture. And it's kind of a good description of sepsis care. And especially even in the era of evidence-based medicine and in the era of guideline-based medicine and Institute of Medicine and CMS guidelines on how to treat sepsis, and we will get into that. So it took until, this actually was a CDC guidelines thing from August of this year. They finally said that sepsis is an emergency, okay? It took, I don't know, from before the birth of Christ to like last month to figure out that sepsis is a bad thing and an emergency, and have the CDC say so. So now it's an emergency, congratulations. So they're putting out things like this that go to the mainstream media. It gets posted, sent out to your doctor's office. It's on a poster on the wall. Great, sepsis is bad. If you're driving down the street, there's actually, I think it's up towards Cohoes or Waterville, a sign for sepsis. You know, time is critical. Okay, so this is something that's even. There are billboards. Okay, big campaign thing. So prevent sepsis and recognize it earlier. Don't leave Granny to sit and rot at the nursing home from her UTIs. Okay. So going back, 1990s, we kind of was the first time we said we should really come up with a diagnosis for sepsis. Okay. So this is where the whole thing that you learned in med school, the lag of knowledge translation, of SIRS plus an infection equals sepsis came from. Okay, so SIRS, sepsis. There's overlap Venn diagrams. How many people went to liberal arts college and learned about Venn diagrams? Downey, I know. All right. The problem is that SIRS are really, really non-specific. The whole point of this, of SIRS criteria and definition of sepsis, is to allow research. Okay. It's not necessarily designed to be a bedside tool, okay? But what happens is, this was written by the Society of Critical Care Medicine, my people, and the American College of Chest Physicians, who are the medicine poem folks, Greg's people. And they said, hey, here's this out. They put this statement out, and guess what? Everybody gloms onto it and says, this is what our definition of sepsis is going to be. Including this guy. Anybody know who that is? Yeah. What is he? Emergency medicine, surgical critical care. So, works at Henry Ford Hospital. He says, I've got this great idea. I'm going to protocolize sepsis care. Okay. So, what he does is he puts up this protocol where he says, great, we're going to randomize people to either get this or regular care in downtown Detroit for sepsis, which usually involved sitting in the hallway, dying slowly, versus getting kind of the reactive medical care, like, oh my god, this patient's really, really sick, intubated and all that stuff, versus protocolized care where, hey, this person's really, really sick, I'm identifying it early on with the definition of sepsis, I'm intervening, I'm intubating them, I'm resuscitating them volume-wise, I'm putting in a central venous catheter, I'm putting in a pulmonary artery catheter, I'm putting this patient into my emergency department ICU where it is a single physician, single nurse coverage to, I think they had 6 beds there in their unit, which is totally like every emergency department ever, right? Totally like ours. You can totally just sit there and focus on a patient and bill 6 hours of critical care time. I'm going to give them crystalloid or colloid. It doesn't matter which one. If their CVP is less than 8, I'm going to get their MAP up over 65. If their MAP is higher than 65, higher than 90, what I'm going to do is I'm going to put them onto some nitroprusside and dilate them out. I'm going to transfuse them if they have a low SCVO2. I'm going to put them on inotropes if their SCVO2 remains low. And if I achieve those goals, great. If not, I'm going to go back and do it all over again. I'm going to do things in 3 hours and then 6-hour bundles. Well, he actually reduced mortality from about 45%. 45%, like, that's insane. Can you think of anything else that kills about half of people that get it? That's a sick group of people. The problems are, it's a single site. It's just his hospital with the 6-bed emergency department ICU where all these sick people go. They're putting in freaking continuous cardiac output swans into every patient in this study. How many people have ever put a swan in this room? Hanowitz, of course. Tom. Wu probably has. How many have done it in the emergency department? If anybody raises their hand, I'm going to smack you. Okay, good. Great. Industry sponsored. There are some weird things that happen in the study. There's about, I think, 12 or 16 patients that randomly disappeared. Which, it was a fairly small study, only a couple hundred patients, so that may have swayed some things. We don't know where they went. This is not practical. This is not anything that you can do everywhere. And we'll come back to that. So we have that paper that comes out. Great, wonderful. Sepsis is really bad. We need to identify it early. We need to treat it aggressively. So, Greg, this is killing me, dude. My picture died. So basically, well, even though the slide doesn't work out so well, what happened in 2003, 2002, they said, hey, it's been 10 years, let's look at our outcomes, let's look at what is sepsis. So basically, sepsis becomes like fever, surge criteria, and then a whole bunch of different other things. So white count a little elevated, red count a little bit low, platelets a little bit low, and a whole bunch of other things. So it's just sepsis and a couple other things. So what happened is everybody ended up septic, okay? Society of Critical Care Medicine rolls out this Surviving Sepsis campaign thing. They said, oh, we need to do this. Everybody needs to be treated aggressively. We need to identify sepsis really, really early. And, man, this is bad. It's gotten off like most of my stuff. So, again, sepsis is infection, surge criteria, plus a whole bunch of other crap that may or may not be related at all to sepsis. You start screening in a whole bunch of people that aren't really septic. They make these bundles, which again is cut off, but within 3 hours you need a lactate, you need blood cultures prior to giving antibiotics, you have to give broad spectrum antibiotics, you have to fluid resuscitate your patient. After that, you need to get a central line to them if they don't respond to fluid resuscitation, get their MAP up for 65 within 6 hours. Let's see here, what else? Keep resuscitating them, measure their CVP, measure their SCVO2, remeasure a lactate if it was elevated. Okay. And I can tell you why I hate all of these things in a second. Well, really bad thing happened in about 2012. This guy right here, his name's Dory Staunton, he died. He was septic. He had a scrape on his knee for playing basketball. He ended up with, I believe it was group A strep, bacteremia. He went to the emergency department. He was a little sick. He had a little fever. He was a little tachycardic. He got some fluids. They drew some blood work. His band count was not resulted when he got discharged. Whoops. His band count was like, I don't know, 30%. He got discharged. He didn't get started on antibiotics. He came back dead 36 hours later. The really unfortunate thing is that his parents were very well connected in the New York City political scene. So now we have a law that what we have to do here in New York State is, let's see if these pop up, have an evidence-based screening protocol for sepsis. We have to report compliance of that screening protocol to New York State Department of Health, and we have to report our risk-adjusted sepsis mortality figures on a regular basis to DOH. Those are publicly reportable, okay? So this is the sepsis screen that comes up every time that you have a patient that has a heart rate of 100 and a low fever, and they may be a little tachypnic, okay? I got that walking up the stairs from down the street, okay? I screened it. You're not treating me for sepsis because I actually have a cold too, so I don't know. I need some Zosyn. So to continue the insanity, in 2015, CMS, the Center for Medicaid Services, basically said that we have to follow these bundles, okay? We need to basically look for signs of organ dysfunction. If they have SIRS criteria, we need to document severe, and even if somebody documents severe sepsis or concern for sepsis or possible sepsis or septic shock, even this is coming from an urgent care. I'm an urgent care doc. I was an urgent care doc last night. Some fool at urgent care who's a family med doc who said, I think this patient's septic and just wants to get them out of their waiting room or out of their department, says that. You need to, at that point, scale up and do this full workup, okay? You need to do all the things, all the bundles we just talked about. So initial lactates, broad spectrum antibiotics, blood cultures, repeat lactates. You have to give everybody 30 cc's per kilogram of crystalloid, okay? They don't specify if that's ideal body weight or if that is adjusted body weight or if that is true body weight. So you're going to give your 300 kilo guy who just rolled in off the street into your department 30 per kilo. That's insanity. That's like that's like multiple gallons of fluid. Okay. What if the patient's got congestive heart failure? What if the patient's not got functioning kidneys? What if the patient's not fluid responsive to your first 10 cc per kilo bolus? So you're required to do that, or document why you didn't. You have to perform some sort of volume assessment. Okay, so CVP, you have to measure their IVC collapsibility. Everybody that's rounded with me knows that I hate all of these things. You need to do a passive leg raise test. How many people have done a passive leg raise test in the emergency department? Greg. I know I can pick on Greg and Chris most of the time. So mainly because I think I made you do it. I don't know. That like all my pelvic exams.
It's friendly. The two are related.
They are. Anyway, and broad spectrum antibiotics, literally for everybody that you think might be sepsis. So it's a good idea, but if somebody who's got flu and is septic from flu, you're giving broad spectrum antibiotics because it's the middle of flu season, and they have a positive flu swab, you're still required to give it until you get that flu swab back. So some of these requiring everybody to get these broad spectrum antibiotics and these huge workups may not be the best use of the limited resources that we have in healthcare. So we're a little short-sighted on that. So this is all part and parcel of the protocol-based medicine era that we live in. Welcome. I'm sorry that you were born into this. I was too. We have to deal with it. The problem is that bundles may not have been, yeah.
Sorry. With this whole evidence-based criteria and the new SOFA criteria defining sepsis or who might be septic, how would that apply? Because we're using stuff like ultimate status.
I'm going to show you. That's the rest of my talk.
Sorry.
So, hold on to your seats, get your popcorn. Okay. So there's conflicting studies on whether the bundles actually work or not. So that's why it's labeled with the qualifier of these bundles may work, but it's not definite. So the problem is all of this is non-randomized data. It's just kind of thrown out there. There's confounders that you're actually measuring sepsis and you're actually doing a sepsis study. So there's a lot of Hawthorne effect that comes into this. So again, I'm sorry, I apologize for Greg's crappy technology. It works on my computer. So really cool study that actually was done in the emergency medicine literature where a hospital system, I believe it was Kaiser, tried to roll out a sepsis protocol in their system. So they have 3 epochs. The epoch 1 was before, it's just kind of a historical control. Epoch 2 was where they said, hey, we've got a sepsis protocol, you all should follow it. And Epoch 3 was where they had posters and all that crap where they really thought they should follow it. So what they found is if you look at their, oh man, that's really not good. So if you look at their admission rates overall for sepsis, their admission rates climb over that time from 35%, 42%, 65%. If you look at their mortality from sepsis, it actually goes down. Great, but you're admitting more people with sepsis. So when you actually adjust it to really reflect the mortality of sepsis normalize it to the number of people that you're admitting to the hospital, what happens is your mortality actually increases. Okay. So you're admitting more people, less of them are sick, less of them actually have sepsis. So is that treatment that you're giving them helping them or hurting them? I don't know. Are you giving them too much fluid because you're giving them 30 cc's per kilo? Did they have some sort of complication from the antibiotics? It's impossible to tease out. This is kind of one of those big data mining things.
What study was this?
This was out of the American Journal of Emergency Medicine in 2014. The link is right there in the bottom for you. Okay. And I'll send you the slides. Okay.
So their adjusted mortality went up.
Yeah.
And it's like horrifying.
Yeah, with sepsis bundles. But if you just look at the simple, hey, here's my mortality from rolling this out, just the gross mortality of people that you've defined as having sepsis, that have an ICD-9 code of sepsis, septic shock, their mortality decreases. So it's how you skew the data. It's how you think about the data. When you call everybody, again, we fall into this problem with the Venn diagram where all of a sudden using SIRS as your screening tool, everyone is septic. That's not that you get into into trouble. Okay, this was never designed as a screening tool. All of a sudden using it as a screening tool.
Sorry. Another question I have is how strict are they in terms of screening for patients with sepsis? Because there are a lot of patients who come in through triage for maybe a little.
I don't know, because it's a population-based study. So what happens is So this is exactly what the Hawthorne effect is. So you say, hey, I'm going to do a study on sepsis. Everybody needs to look at sepsis. Follow this protocol on sepsis because you're required to. Here's your flag that you have to answer. Is this patient septic? When you get those things, you're like, well, maybe the patient is. So all of a sudden, now you have a CMS regulation that says you have to give this patient 30 cc's per kilo of fluid. whether they need it or not, it's a regulation that you need to follow or document why you didn't follow. It's easier just to give the patient fluid than to figure out why you're not. Okay, so what happens is people get extra fluid, they spend more days in the hospital, they get fluid overloaded, they go into CHF, and then they have a higher mortality rate because you're causing complications with what you're doing. So what this is a plea for sanity, which we're not going to get because of CMS. So one of the problems is that, and again, woo! I'm going to send Noah a text right now. I rely on like heavy graphics, and here we go. Anyway, so another study. I love just putting up pieces of literature. So another study published. You know what? Half the people that get admitted to the wards end up with SIRS criteria at some point during their stay. So now you're saying everybody that screens in for sepsis or screens in for SIRS criteria has to be, you either have to say, oh, treat them for sepsis or don't. Now that is being given to, and I apologize, an intern or a second-year resident who doesn't really know the patient because they've got 80 patients on their service, and they're like, well, screw it, just give them broad-spectrum antibiotics. You end up with things like the highest rates of C. diff in the state, like Albany Medical Center. So this is something that has downstream effects. You've got good intentions, it's not great. The other problem is that SIRS sucks, okay? SIRS misses 1 in 8 patients, okay? There's this thing that's called SIRS negative sepsis, okay? Where you have 0 SIRS criteria and you're still septic. And guess what? You don't screen in, you don't treat it appropriately because guess what? You didn't have SIRS. So, ends up being about 1 in 8 patients, okay? In this study, came out of Australia. They don't die at a higher rate. They actually tend to be a little bit less ill. Their mortality rate's about 16%, whereas SIRS positive sepsis was about 30%. Okay. They had end organ dysfunction, but they had negative SIRS criteria, and they were infected. He got discharged with the diagnosis of sepsis. Due to positive blood cultures or whatever. Well, this is admission SIRS criteria, so they became septic later on. So using SIRS as a screening tool for sepsis sucks, because guess what? You can become septic afterwards.
Just a question. So, if you were to culture every single patient in the hospital right now, how many of them would have a positive?
Good study. I'm not doing it.
Like, what's the baseline? In other words, so half the people.
And what's the false positive rate? And what's the false positive rate? And we put everybody on freaking antibiotics that walks through the door because of these stupid laws. So, and how many people of these have viremia? How many of these people have fungemia? How many of these people have other things going on that would cause them to have fever? Drug fevers, DVTs, etc.
I feel like when the nurses come to me and say they're sepsis positive, I just say,
great, I don't care.
Alternative cause. And
Yeah.
we all move on with our lives.
Correct. But 3 o'clock in the morning, when you're the one person on covering the entire surgical service and you're the internal of, fuck it, give me antibiotics. That happens. Even if you do that 1 out of 8 times, you're still treating a large proportion of your patients inappropriately. Or a lot of times it's because you're just bombarded and it's task overloading and things like that. So the problem with this original Manny Rivers thing is that since that initial publication, there have been a lot of things that have been disproven in the literature. So CVP is one of my favorite easy targets. CVO2 has gone by the wayside in terms of looking at cardiac output and putting swans into everybody. There's very good data showing that using swans actually increases your mortality and complication rates. What else here? Transfusion in sepsis, transfusing up to a hemoglobin of 8, no longer recommended, or hematocrit of 30 definitely causes more harm. Using inotropic agents, dobutamine's been shown to have putting patients on dobutamine has been shown to have worse outcomes than sepsis. Things that have worked, giving them fluids, making sure the MAPs are about 65, and yeah. Then there's these big 3 trials, which we covered at Journal Club last year, the ARISE and the ARISE Process and Promise. So these were the big mega trials that essentially randomized people to get either standard care, or which is not protocolized care, which is not putting swans into everybody, or doing the non-invasive protocol, which I didn't cover here, but I don't want to cover because it's too much literature already. Versus having the straight literature definition of many rivers. So basically, all 3 of them said,
I know.
So the other thing that's actually really useful was putting your patients on broad-spectrum antibiotics, and there is a thought that time to antibiotics after becoming hypotensive improves outcomes. This graph from this paper worked out way too well. This is mortality and time after hypotension. It's linear, but there are a couple of papers that do suggest that time to antibiotics is something that improves mortality. So putting patients on appropriate broad-spectrum antibiotics works, most likely. But it shouldn't be a linear correlation like that. It's a little bit weird. So this is a process trial. Basically, if you look, protocolized care versus, they had 2 different types of protocolized care. They had the straight Many Rivers style. They had another non-invasive protocol, and then they had a third kind of willy-nilly do what you want to do kind of treatment protocol. So one non-protocolized treatment, and they had about equal mortality outcomes. So the people that were in the protocolized treatment arms ended up spending a few more days in the ICU. They went to the ICU at a much higher rate, about 5%. So the one thing that you can say is that your resource utilization in people is higher when you have this protocolized care. Does it improve outcomes? No. Does that clog up your hospital with patients who need more days in the ICU? Probably, because they're getting more fluid. They get about 1.5 liters more fluid on the protocolized care side of things. So again, our ARISE study, this is the Australian version of it, and same thing, just different directions. So they do survival instead of death, and there's no real separation between the curves. Their group, kind of similar, nothing really different in terms of the outcomes that reach statistical significance. The next thing was this is the British version of it, okay, which is the Promise trial. So again, nothing really, no separation between the Kaplan-Meier curves. Again, this one showed a little bit more fluid in the protocolized care group versus the kind of standard care group. So what these trials have done, and what all the sepsis literature over the past couple of years have done, is they made me kind of a bit of a nihilist. So for anybody that's not seen the movie, I apologize. These are the nihilists from The Big Lebowski. So you just have to be careful about your reading. Half or more of what you know will be reversed in the next 10 years. Even more of that will be reversed and about another 10 years after that. So hanging your hat on evidence-based medicine as the absolute correct way to treat every patient every time is probably not the right way to go. And kind of strictly saying that this is absolutely what I'm doing, and I'm not going to flex. I'm not going to look at the patient. I'm just going to give them, 30 cc's per kilo and put everybody on Zos and Vanco is the right thing to do. I don't think that's the way that medicine should go, but it's kind of where we are. So there's this thing that came out in February this year. It's called Sepsis 3.0. We realized that, hey, this is insanity. This is not going the right way. Where basically those 2 studies I showed you earlier, that SIRS misses people that have sepsis, and that half of people have SIRS and are being treated for sepsis inappropriately. They said, is there a better way that we could study this? Is there a better way that we could try and predict somebody's mortality when we think they're septic? That's all that QSOFA was designed to do. So what they did is they, at the University of Pittsburgh, derived this score called the QSOFA. And what is quick SOFA, sequential organ failure assessment? They looked at a whole bunch of variables that are in the SOFA score, which is the sequential organ failure assessment, which is a long involved, like 13-point assessment, including labs and all that. They said there's something we just walk in the room, look at the patient, and say, hey, this patient's sick and they have a high risk of dying. So that's where QSOFA came from. It's not designed as a screening tool. It's not designed as a triage tool. It's designed as a thing that you can then study, okay, when you're going back and looking at patients. It's designed to be something that's easy to use, but it's not designed to trigger treatment, okay, which is what all the SIRS criteria ended up being used as, okay. So this is not what it's intended to. It's not intended to kind of do what we've been doing with SIRS. And that's directly out of the mouth of the guy that wrote the study. So, sepsis is now, instead of SIRS plus suspected infection, it is suspected documented infection plus a score of 2 or 3 on the QSOFA score, or a rise in SOFA score for an inpatient in the ICU, going up by 2 points. Okay, so you can't use QSOFA in an ICU setting because your patient's probably not going to qualify for its use, and it was not derived in an ICU setting. It was designed in ward patients and in emergency department patients. Okay, so severe sepsis is not a thing anymore. Okay, there's just sepsis, and then you have septic shock where somebody needs vasopressors to keep they have sepsis and they need vasopressors. Okay. So, and they need to have a lactate that's greater than 2. So, all the people with lactate of like 1.8 and they're just on a little bit of pressor, no, they don't count as septic shock anymore. Okay. All that QSOFA is low blood pressure, altered mental status, and tachypnea. Okay. What's the problem with tachypnea in our institution? Everybody has a respiratory rate of 6 to 8. Nobody's tachypnic. So nobody actually measures it. This is something that we have to work on compliance with. This is something that's going to take years to change, and it's all about changing hearts and minds. So one way to remember it is HAT. The other way to remember it is BAT. So just trying to make it easy. These are foam things. I thought they were cute. So again, sepsis is now not just an inflammatory response to an infection, okay? I don't know what it is anymore. Sepsis is it's changing, okay? So this is just the SOFA score and all of its glory and pain and annoyingness. It involves coagulation problems, respiratory problems, the P to F ratio, the problem being that, again, these things get all wonky for multiple reasons. Okay. So how do I use it? So how do you use it? Basically, what they're intending you to do is say, hey, patient got an infection. Hey, what's their QSOFA score? Is it greater than 2? Yes, great. Is there organ dysfunction? Do a SOFA score. Is there evidence of SOFA positive organ dysfunction? Great. They're septic. Yay. Then we'll treat them. So what it's designed to do is make you think, is the patient septic? Okay. That's all it's designed to do. It's not designed to trigger a treatment pathway. It's designed to trigger you to look for end organ dysfunction. Until they have that end organ dysfunction, they're not truly septic. Okay. So that's really it. So, where do we go from here? All right, what's up?
Has anyone looked at whether Rory Stone would have met the QSOFA criteria?
No, not that I know of.
Not for
He probably had a respiratory rate of like 16 because he was at a big, busy New York City pediatric emergency department.
probably not validated.
Yeah. Because and is a 13-year-old the kid still or not? Who knows? So it's one of those like, I don't know. He'd go to a PICU, but is he physiologically a child? And at what point does he do that?
It's tender stage.
And I don't know that. I completely agree with the Tanner stage stuff too. And
Luke, are you using fecal pH as a predictor of mortality like the genetic disorder?
Absolutely in every patient. No.
I heard about that.
Are you listening to podcasts? You should stop. I'm just kidding. I highly recommend that you measure fecal pHs in every one of your patients, especially up at Glens Falls next year. You report that to your intensivist up there, and actually call the transfer center and have them page me directly. So where the hell do we go from here? Well, again, I'm sorry, I'm now a nihilist. I don't know. Are we going to change our sepsis protocols? We can't. Why? Because CMS says we can't, and New York State law says we can't, and we spent hours and tons of money on developing these stupid screening protocols, and now we're stuck with them, because guess what? They're reportable. Guess what? Since 2014, when the New York State law came out, how many times has DOH actually published those numbers? A grand total of 0. A quick Google search will show you that that number does not exist. Okay? So, how many hours were spent actually developing it? Well, probably about 100 committee hours, which, if you talk to Rachel Heinerman or Dr. Cohen, they wanted to kill themselves after those meetings. So we have to try and figure out where QSOFA fits into this. We have to figure out a lot of things. We're kind of back at the beginning again of sepsis research. What does this mean to you? Probably nothing. But all this was designed to do is give you a little look into the insanity of all of this and all that is sepsis and critical care and the crazy world we live in. So, I'm not going to talk about fluid responsiveness. I had this on as a kind of tag on when I wrote the lecture the first time. This, I think, is probably the biggest thing that you can learn how to do is figure out fluid responsiveness. The big problem is it is the holy grail of critical care and how to figure out how to give a patient just the right amount of fluid without drowning them. There's an article that Paul Merrick wrote about 2 years ago now about the syndrome of iatrogenic saltwater drowning, which is what he views the Manning Rivers trial as, where you're just giving people 30 mLs of fluid, and then 30 mLs of fluid again, and then 30 mLs of fluid again, just because they're hypotensive. So what I ask of you guys is, when you have somebody that's hypotensive, if they're not responding after 2 or 3 liters of fluid, please put them on pressors, okay? Please, don't give them 9 liters of fluid. That's insanity. I'm guilty of it. I did it as a resident. I didn't understand what I was doing when I was doing that. Just please think of it. Don't be afraid to put in central lines. Don't be afraid to put in arterial lines. Don't be afraid to scale up, okay? Don't be afraid to call your intensivists early, unless it's the MICU, when they'll push back and say, no, the patient's fine now. But they're intubated on pressors and dying. They probably don't belong in the MICU. I'm just kidding. No, they do. they do take care of sick patients. If you really ask them to come down, if you really feel like you need help and you need to get the patient to the SICU, you can always, or to the MICU, you can always call their attending. Their attendings are actually fairly reasonable human beings. The problem with fellows, having been a fellow, is nobody wants to do work, and when you're not incentivized to do work and you're just beaten about the head and neck, they're going to push back. So if they ever give you trouble, call their attending, have your attending talk to their attending, say, this patient's really stupid sick, they need to come to the unit. They just don't want to do work. Great. Questions?
So, 2 questions. First one is, I've seen different criteria for doing 30 cc per kg in terms of whether or not the patient is hypotensive, or they have to lactate, or they're just meeting the criteria for sepsis.
Mm-hmm.
And then the other question I have is, when you have a patient who's already over 100 kilograms, and you just advise us to give, I'm assuming that normal healthy patient is 3 liters.
Yeah. So in your 70 kilo guy, how much is 30 cc's per kilo?
2100.
Great. You guys can do math. So, do you get extra intravascular space that's storing your blood? Do you get extra floppy vessels sitting in your legs and extra capacitance vessels because you're fat? No. So that's basically how I do it. That's how I think of it anyway. No, you don't. It's not because you're 150 kilos, because you're 200 kilos doesn't mean that you can store more fluid. It just means that you're fatter. It doesn't make your vessels any different. So give them ideal body weight. It's probably the best way to go. Your obese patients are even more compromised and even sicker and even harder to take care of. So, and part of the reason is that people just don't think and they just keep giving them fluid. So treat them as the skinny people they are on the inside. In terms of the criteria, and that goes for all aspects of their care, except for their airways. Be very, very afraid of their airways. In terms of the criteria to give them more fluid, if they don't respond to 30 cc's of per kilo of fluid, they're probably not going to respond to 60 cc's per kilo of fluid. They're probably, and you're giving them crystalloid. How long is it staying in their blood vessels anyway? They probably need to be squeezed a little bit. So there's no harm in putting somebody on pressors except that you need to send them to an ICU bed. And if you're giving somebody 60 to 90 cc's per kilo of fluid, they probably should be going to an ICU anyway because they're going to end up in pulmonary edema anyway. So, you're going to put in a central line. Why are you giving up why are you sending people away without their toys? Just put your toys in, okay? You're ignoring your patient because you're in a rush. You can do it. You can put it on to save their life. Yes, there's actually a really good study out of Long Island Jewish Hospital where they have about 600 patients with peripheral pressors. You have to have a really good peripheral line. You have to have a really good nurse who's going to watch for an extravasation. Okay, that's how people lose arms. I've seen it. One of our cardiac anesthesiologists now has a mother-in-law who has no hands and 1 foot, who's living in India because of pressors. So they are really bad.
Oh, she made it.
She made it. Yeah, she's in India.
Okay. Well, I remember that patient.
We don't have a protocol for control the injection.
Yeah.
Long Island just had all of that.
Yeah. So what they did is they protocolized it and they said, hey, this patient's on peripheral pressors. Look at their freaking arm. Did they extrav? They had something like 17 extravasations, and of those, 0 lost limbs, 0 had skin necrosis, because as soon as they extraved, they said, well, that, and they're looking just for pallor around the IV site. What they did is they withdrew it. They withdrew the IV, sucked out the puddle of pressure that's sitting under the skin, actually surgically drained the area and injected phentolamine. So it's nothing that we have here. Do I think it's smart to do? No. If it's going to keep your patient from dying while you're putting in a central line, it's fine to do. Don't do it because you're in a rush. Don't do it because you're being lazy. Get your freaking line in, okay? Even if you do a crashed line on somebody who's dying, I'd prefer that than somebody coming up with a peripheral 24 hanging out of their pinky with a pressure of crap on crap. Okay? There's no such thing as rush. There is fix the patient. Yeah, so if they're tanking, they need a central line even more. Run it peripherally while you're putting in the line. Yeah, you can do it. That's absolutely fine. But put in your central line because it takes 5 minutes to do a crash dirty line. Okay, that's what I got, guys. Thank you. I'll send out those to the group since Greg broke all my slides.
I break many things,
including my will to live. That actually is, yeah, so that correlates to crap on crap. There's actually just a poo emoji over a poo emoji. Yeah, so there's actually a clinical score called the
Crap on crap score?
no, Weingart looks like shit score. It's called the wall score. That's my favorite picture of responsiveness I've ever seen. Which was that favorite movie? Indiana You can do that.
I am
That's
pro
fine.
push dose antibiotics.
The hurdle was, I think,
Now we're
Not
supposed to
for
do
banks.
continuous flow
no,
antibiotics.
it was like the
I'm sorry about that.
stranglehold over not
It was
just
a good talk,
antibiotics,
though.
but the packaging.
You wanna go
That's why.
No.
That's why we
I
don't.
know I look like as I lecture. I've actually watched myself on video before. It's painful.
Somebody at some point made the 1 hour bags, and they're doing it.
Well, the other thing is so when you look at the pharmacodynamics of things like Zosyn, and killing time is related to the administration of antibiotic. It's either the maximum peak with things like the tablet.
Welcome back.
Right?
You're next.
Yeah, sure.
Whenever.
Versus time above MIC.
We're streaming. We're trying to stream lectures now.
Ooh, famous. Does that mean I can get credit for being here without being here?
Maybe.
So
haven't gone
do
that far.
if I,
Do you have your time?
it's in my it's in my email.
Okay.
Oh, this is a bad angle for me.
Our institution is
No.
There's that
like
camera
4
over there.
hour infusions of Zosyn.
Do you want? We can move the camera.
So it goes in over 4 hours. You have 2
How
hours
have you
off.
been? I feel like this is the first time I've seen you since
So
you
you're
left.
staying above for a longer.
Life is different with baby.
I can only imagine.
Dude, so different with baby. All right, so this is
Oh, that mouse isn't
wrong
connected.
mouse.
I know it's way above.
Just be aware it may log in as me,
So that's
but
why
it's
they're
okay.
doing push the antibiotics is because you gotta get it in, you wanna get it in, you wanna get it fast, it spikes their concentration. So
Yeah, because the candidates are being banished off to Hackett.
it doesn't like it's not like
So we're trying to say, you know what, if we're going to invite you for lecture day and you can't be there for lecture, we might as well actually just kind of show you what lecture is like.
That
really stinks.
You know, you didn't hear about this?
No.
We're moving next week.
Yeah, well,
Yeah.
so they're not going there,
They're going to be at Hackett from like 8 a.m. to 11
and we're doing our.
in like MS 169. Because I don't know if you've seen the new office space. It's like closet. It's like P buildings,
Dude,
smaller.
my office still has the like comic on the ceiling from when women used to get pap smears, and they'd have something entertaining them while some dude was all up in their business.
If it's in
Am I
consolation.
streaming right this second?
Yes, Matt Maney, I'm sure, is enjoying it. He's watching from the airport. If it makes you feel any better, then when Pulmonary takes over the office, they'll probably just leave it and it'll still be weird.
Oh no, I'm taking it with me. It's going on the
Oh,
ceiling
okay.
of all my offices from now on.
I was going to suggest the Pulmonary that Jetson's office should be. So whatever size.
Why is this different? How do I make it go? All right, much better. Oh, look at this fanciness.
I think it's a cool thing to talk about on this podcast.
Hi, Matt.
You're a couple minutes early.
Super cute shirt.
Which is actually the goal of every one of my talks.
I just got a text from doctor. Yes, I have a patient so he said she had a
Okay, and I forwarded it to our group to forward to, so they should have it as well.
Okay. Should I receive it now or wait
Until after. Yeah, you can also, if you're not sure, is it okay? Whenever. Yeah, just wait. Because this is probably more important unless that's the patient, she came in last night. At some point, just look up blood pressure and know either in micromedics or already down there. It's fantastic. Yep. It's annoying because we have to update it constantly, but I use it for everything. That or, and I'll forward you guys, it goes week to week, so Adam's going to be on this entire week, and it's occasionally we'll swap between each other, but if you text me and I can text you, not just yet. Or if somebody happens to be in the ED, just touch base with them. Like if they're swamped, they might not be able to start the patient with you, but if it's somebody who's sick or like quasi-sick, then I can kind of which is kind of nice.
Alright, I just wanted to check early when you leave.
Yeah, go see the patient and then history and all those patients is a little thorough. Because I feel like you don't need to know if their pain is radiating. They really just want to know what they took on their ticket. And you really can't, I don't know, what were you watching on TV? Were you watching, you know, was it after dinner, was it before dinner, was it dark out? To try to really narrow down on the ticket. And the formulation is really important. There are patients that have 6 or 8 day formulations. So if they know it's an extended release, is it immediate release, like they're not sure if they take once a day, they take twice a day. A lot of the stuff we're talking about today is stuff that we have in yesterday that has a lot of pictures. And I realized about 10 minutes ago that I had forgotten to take a picture of my daughter in my PowerPoint presentation, so I had to after that. Hopefully we'll get to the end so you can see it.
And then just like about the dictation, I didn't see anything like that on Dropbox.
Yeah, it should be in the Dropbox. Yeah, I'll forward it to you if it's not, because my Dropbox is bad at me. So I had to like rearrange everything. And there should be cases, there's a couple interesting articles. I'll double check that it's there as soon as I'm done with this, and I'll just forward it to you. It'll make it easier. It has the phone number, so just a couple of items to read off. And at some point I'm going to put some examples of
Alright, so it's cool if I like save the picture and then go after.
yeah, just text him and be like, conference ends at 1. Is it cool if I wait?
Okay.
All right, Woo, I broke it.
I think it fell.
Did it?
What did we do?
I just pressed over. I didn't do it.
Oh, you know what? The projector fell asleep. Projector
I
turned?
swear to God, I used to be like,
Oh, you know why? Because they put these in the plugs. It's funny, it's easy like There we go. We're back.
You just hit F6. It's funny, I used to be like not technologically targeted. So, and now I totally am.
It happens. I'm not looking forward to that day. It's gonna be. The irony is gonna be painful.
Oh, some people are okay. I mean, I was never that person. I'm still upset that we don't have paper charting stuff.
I think those days are gone, unfortunately.
Yeah. I like downtime so I can write things by hand.
I miss the days when I could dictate.
I hated dictating at the time, but I hate our current charting even more.
Yeah.
That dictating's not so terrible.
In the grand scheme of things, I think I prefer. Thank you so much.
All right, you guys want to get started?
Yeah, let's do it.
And question, is there a laser pointer somewhere? I normally just use the mouse. No?
No one else has been using one. So
I'll use my hands. It'll be good. We can do this. All right, guys, so I'm Molly Boyd. I'm one of the medical toxicologists. There are currently 3 of us that you'll all be meeting in the department, and during your toxicology rotations, fingers crossed, we are hoping to hire a 4th, so I'm no longer on Q3 call because Q4 call is way, way better. Don't forget, when you do have tox patients in the department, give us a call. If you're not sure if this is a patient that requires a tox consultation, give us a call, drop us a text. Are you interested in seeing this patient? We're happy to help you co-manage these patients either through a phone call or a bedside consultation. And the Poison Center is available 24/7. So today we're going to talk about some over-the-counter pain meds, And you're going to be seeing these patients all the time. Like, people accidentally overdose or purposely overdose on their pain medications, and over-the-counter meds are available and people don't realize that they're toxic. So if one Tylenol works okay, 10 Tylenol might work a little bit better. And one of the other fun things is somebody's like, yeah, I took 10 Tylenol or 10 pain medications, but they don't actually know what's in it. They say they took Tylenol, they actually took aspirin. They say they took aspirin, they actually took ibuprofen. The lay person does not know the difference between these medications. The lay person takes Motrin, but they don't want to overdose on Motrin, so they take ibuprofen at the same time, and they don't want to overdose on that, so they take an naproxen. So being aware that there might be patients who are really trying to not take a Percocet, not do the wrong thing, but they're taking too much of their medications, and you're going to be seeing this all the time. So this is an example of a patient you're going to see on a regular basis. So it's 10 o'clock at night, you're in the D zone, and a 15-year-old female presents. She has a history of depression, and she wants to end it all. She's tired of it, so she took 2 handfuls of headache medication. She took it about 12 hours ago, and she came in because she's having nausea and vomiting. So what's this headache medication? Like, list off some headache medications somebody might. Excedrin. What's in Excedrin?
Acetaminophen and caffeine.
And sometimes it has aspirin in it as well. So there's like different formulations of Excedrin. Any other headache medicines that somebody might just take? Fioricet, not necessarily over the counter, but that contains Tylenol. It contains caffeine. It also contains butalbital, which metabolizes to phenobarbital, but they might have access to that medication as well. Any other medications? What's that? Yeah, Motrin. They might have taken Motrin. So you don't even know what this patient could have potentially taken. So she's in D40 or D45. What labs are we getting on this patient? What's her dispo, first of all? Like CDPC versus admission, right? So what's the CDPC labs? What labs are we getting on this patient before you even talk to her? Urine pregnancy as well. So CBC, CMP, serum drug screen. What's in our serum drug screen at Albany Med? Because it's different everywhere. You can't just go to your outside facility and be like, I want a serum drug screen. The nurses are going to look at you like you have 3 heads. Exactly. So that's going to cover a vast majority of headache medications. Why those medications? Anybody but Chris, because we talked about this yesterday.
Because you can intervene on those medications?
Exactly. So for Tylenol, it's super duper common. People are accidentally overdosing it. It's in NyQuil, it's in Excedrin, it's in a number of different medications, and there's an antidote. Aspirin, it's in a number of different medications. There's an antidote. Alcohol, everybody's not drinking alcohol. And then there's tricyclics in our SDS, our serum drug screen. It is a meaningless lab. I have no idea why we're still using this lab. If it comes positive, you have to pay attention to it, but if it's negative, it does not mean that patient didn't get TCAs. As a matter of fact, the test for TCAs is not a drug screen. The test for TCAs is an EKG. So, you order your labs, you are waiting on those labs to come back, and her initial labs are as follows. So, what did she take? She took Tylenol. So at the 12-hour mark, her level is 152, and incidentally, her aspirin level came back negative. Her ETOH may have been plus or minus. I don't really care what her TCA was. But these are the really important labs. So this patient, Tylenol toxic, not Tylenol toxic? Okay. And what's our treatment? NAC. Okay, done. We're done. That's all you need to know about Tylenol, right? Tylenol toxic, NAC, done. But it gets a little bit more complicated than that, and that's why we're going to spend a lot of time talking about acetaminophen today. We're going to spend a good amount of time talking about Tylenol today, and then a few minutes just touching base on ibuprofen and other NSAIDs. So why do we care about Tylenol? I imagine everybody in this room, in the few months that some of you have been in residency, have seen either intentional or accidental Tylenol overdoses. Poison centers get over 100,000 calls a year on Tylenol alone. And it results in about 300 deaths annually, which in the grand scheme of things isn't a huge, huge number, but what's really unfortunate about that number. Although 2/3 of that is intentional overdoses, either from Tylenol or Tylenol-containing products, 1/3 of them is accidental overdoses. Like my idiot brother who was really sick when we were on vacation a few years ago, and he wanted to go out and he wanted to hang out, so he bought a bottle of NyQuil and he just drank the whole thing so he could go out. And I think I was a medical student at the time, and he had like 4 grams of Tylenol and a couple of Mai Tais. But, I mean, he was very potentially close to being toxic, and he wasn't trying to hurt himself. He wasn't, for other reasons, probably not. But, I mean, he ended up being fine, but no idea. Like, if a taste of NyQuil, it helps, then how about just drink the whole bottle? You'll feel great. Go lie on the beach and wait till your liver melts. So, APAP toxicity is actually the leading cause of liver failure in the United States, and the treatment for fulminant liver failure is either, in essence, although there's some emerging science, is a liver transplant or death, and there's not a lot of livers going around. So, like I said, patients come in and there's a lot of accidental overdoses. And you have to be aware that patients are making these mistakes. You have to have a high index of suspicion for that dental pain patient who says, it really, really hurts. I've been taking Tylenol for the pain. Spend the 30 seconds. How much Tylenol are you taking? How many pills are you taking? And have them lay it out for you. Because if they are taking a toxic dose, you could truly save a life. In addition to just not knowing that acetaminophen is Tylenol, Tylenol is in everything. It's in just about every pain medication or every over-the-counter cold medication. So people are taking their Tylenol, they're taking their NyQuil, they're taking their Theraflu just to feel better, and they're getting overdoses. Most people, it's over the counter. It's Tylenol. I've given it to my baby. It's a fine, safe medication. Most people think that it's completely safe, so they are taking this medication, and teenagers are taking Tylenol in like suicidal gestures, thinking it's, I'm going to overdose, I'm going to kill myself, and I'm going to get all this attention, but it's something that could actually truly cause harm. And lastly, it comes in a million different formulations. So acetaminophen is called acetaminophen. I love structures. I'm really sorry, guys. I have to subject you to this really, really quickly. So you have your acetic acid moiety, your amino moiety with the nitrogen, and the phenol moiety, acetaminophen. Mind blown. All right, so it can come in a million different formulations. This is just a list of some of the things that might contain acetaminophen. Oh wait, we're gonna go there, really? So these are para, because they're opposite ends of the benzene ring. So another name for acetaminophen is acetyl para-aminophenol, and that's where APAP comes from. Again, it's all related to the structure. So when somebody says APAP, it's just them sounding fancy. Naming the structure differently.
But it's so much shorter, right?
APAP, easy peasy. So APAP comes in multiple formulations. Just Tylenol itself can come in, there's the rapid release formulation, there's extra strength, which is 500 milligrams per pill. So you take 2 of those in a dose, you get 1 gram per dose. So if you're taking that dose every 2 hours or so, because your pain is coming back, you're getting 12 grams over the course of the day. That's a lot of acetaminophen. Arthritis pain or Tylenol PM, these are more extended release formulations. So you take a tablet in the morning and you have, for arthritis pain, it has a rapid release portion, and then it has an extended release portion. So again, patients are like, well, I just took 2 Tylenol arthritis, let me take 2 more because it hasn't worked yet, and then you have like a compounded toxicity. So when you're taking Tylenol, 1 gram every 4 to 6 hours, the maximum is 4 grams. in any one day. If you're going to be prescribing this to patients, I don't tell them the maximum is 4 grams. And the FDA says 4 grams maximum daily dosage. I try to stick it more down to 3.5 grams, and that seems to be a standard of care that's developing. But currently the FDA's formal recommendations are a max of 4 grams per day. In kids, 15 mg per kg, we all know this, and with a maximum of 75 milligrams per kilogram per day. If you take the 1 gram every 4 hours, that's going to end up being 6 grams. So if you tell somebody every 4 to 6 hours, make sure you are emphasizing 4 grams per day. Or for the kids, you can even, I just tell them take it every 6 hours because you don't want to have that chronic overdose. When we're talking about overdoses, people that try to kill themselves oftentimes will just take all the pills at once, or all the pills at a short period of time where they're having, their bottle of vodka or what have you. Like a sip of Tito's and a couple of pills, a sip of Tito's and a couple of pills. So oftentimes you're going to have acute intoxications that occur over the course of about 4 to 8 hours. If it's over 4 to 8 hours, we think of that more as a chronic intoxication, and it becomes a little more complicated. We'll talk about it in a minute. But in terms of acute intoxications, patients who are taking it all within a couple of hours, if they're taking greater than 10 grams in the course of one day, or a pediatric patient who's getting greater than 200 milligrams per kilogram per day. So that's just about over twice the safe therapeutic dose. So you have to really try to overdose on Tylenol, but people are doing it all the time. So those are numbers that you're going to want to remember. You have a patient, you do the math, they took over 10 grams or even close to 10 grams. These are the patients that you're going to want to start doing additional testing on. Pediatric patients, how much are you giving? How big a syringe are you giving? How often are you giving it? Because mom or dad does not necessarily use the right syringe, does not necessarily know the proper dosing. How does Tylenol kill you? It boxes your liver, and it irreparably boxes your liver if we don't catch it in time. So you will have slow liver function decline over the course of about a day, and then you'll start with the coagulopathies, hepatic encephalopathies. Eventually you can go on to hepatorenal syndrome. It peaks at around 3 to 4 days, and at that point, depending on the supportive care, how bad the liver toxicity was, the liver either heals itself with supportive care, you get a transplant, or you die. More structures. Okay, so how does acetaminophen kill your liver? When you take acetaminophen, one of 3 metabolic pathways occurs. Everybody has the ability to do some sulfonation. You just take APAP, you throw sulfate moiety on it, you pee it out. Pediatric patients are really, really good at this. They have high abilities to sulfonate, so pediatric patients have a higher tolerance. That's why these kids can get 200 milligrams per kilogram per day and be fine, whereas if we took 200 milligrams per kilogram per day, it would probably cause a problem. So there's a certain amount of sulfonation that everybody's able to do. Glucuronidation, again, you slap a glucuronide molecule onto it, you pee it out, it's gone. A little bit goes out unchanged in the urine, and a little bit goes to the kidneys and is metabolized there. But the remaining acetaminophen goes through the cytochrome 2E1. And you do not need to know that for your boards, but it is a very important cytochrome. There's a lot of different pathology associated with this cytochrome. It takes the acetaminophen and it turns it into this. You'll need to know this for your boards, NAPK. So NAPK is the toxic reactive oxygen molecule that kills your liver. And as soon as NAPK is formed, it's going to bind to something close to it. If you are lucky enough to have a healthy liver that has a ton of glutathione in it, it just binds to glutathione, you pee it out. If you are an alcoholic, if you're a cancer patient, if you're chronically starved, if you are deplete in glutathione because you have no ability to metabolize cysteine, you don't have enough glutathione to save your liver from NAPK, and NAPK is going to start to bind to your liver, whatever molecule it's closest to. And because it's a reactive oxygen species, it doesn't just bind permanently. It's going to bind, it's going to break down phospholipid membranes, it's going to destroy enzymes, and then it's going to move on to the next molecule and do the same. So NAPQI, NAPQI, that is the toxic Tylenol metabolite. It will appear on your boards. If you have glutathione, and a healthy liver has tons of glutathione. A healthy liver has enough glutathione to safely protect you from about 16 grams of Tylenol. So if everyone in here with a healthy liver, and after pregnancy my liver is healthy again, we're working on damaging it slowly but surely. It's hard with breastfeeding. So with glutathione, with a healthy liver, glutathione 16 grams. So if I took 16 grams of Tylenol right now, I'd probably be fine. If a chronic alcoholic took 16 grams of Tylenol, a cancer patient, somebody who's starving, they're going to get sick. They're going to produce a lot of NAPQI. They're going to go into liver failure earlier.
Are there medications that reduce glutathione, like someone might need?
Not to a significant degree, but there are some medications that can increase your 2E1. Chronic alcoholism actually increases your 2E1, so you have less sulfonation, less glucuronidation, and more NAPQI formation in chronic alcoholism. So, so there can be some minor changes, but in the grand scheme of things, you're not going to get so much from another medication that it's going to change that 16 grams to 2 grams or anything like that. So fun fact about Tylenol is cats cannot metabolize Tylenol. They lack glucuronal transferase, so they can't glucuronidate Tylenol. So it causes liver failure and incidentally methemoglobinemia very quickly in cats. However, in dogs, totally safe. That's rookie. And it occurred to me as I was going through this PowerPoint this morning that I had a picture of my dog and not my daughter in my PowerPoint. So I had to make some really quick edits at the end because I'm a bad parent apparently. What does NAPQI stand for? It's N-acetyl-P-benzoquinone imine. I will never say that again. Don't have to learn it. That's what it looks like. When you take too much Tylenol, you take Tylenol at point A for the first 24 hours, you're pretty much fine. Maybe you just don't feel that great. Maybe you're a little nauseous, but maybe you had a GI bug that made you take the Tylenol to begin with. So the physical exam is going to be pretty normal. The signs and symptoms are subtle. So it's, again, high index of suspicion. Not for the suicidal patients. I mean, if somebody's suicidal, you're getting a Tylenol level. It goes without saying. Patients who say, I took all my Wellbutrin, up to 30% of those patients also took too much Tylenol, and they'll never mention it. And we don't know if it's because they don't want you to know they took too much Tylenol, or if they just don't think it's important because it's Tylenol. So these patients you're going to get a Tylenol level on, but it's the chronic patients that could potentially get missed. By phase 2, within 2 to 3 days, that's when you're going to start the right upper quadrant pain. You might have a positive Murphy sign, the AST and ALT, and I'm going to incorrectly use the word liver function tests, and I'm going to say liver function tests, and I'm going to mean ALT and AST. ALT and AST are not liver function tests. Elevated AST and ALT mean that the liver is damaged, that you're spilling liver enzymes into your blood, but the true liver function test is like the INR and the lactate, because this is a synthetic protein that your liver is making, and if you have a incorrect and elevated INR, it means that your liver function is not working. That being said, you check your liver function tests, and if they're elevated, you're starting to go into phase 2. Phase 3 starts at the 3-day point. That's when your liver essentially turns to mush. You start bleeding, you start becoming jaundiced, and you could potentially have renal failure as well. And then phase 4 really depends on how long we can keep you alive. If we can keep you alive until your liver starts regenerating and there's enough liver left to regenerate, awesome, you might survive. If we can't, we can maybe keep you alive for about 2 weeks before you just lose all liver synthetic function and you either have a brain bleed or a hemodynamic collapse, hepatorenal syndrome, et cetera, et cetera. Because a small portion, it's a thought actually, that because a small portion of acetaminophen is
goes straight to your kidneys for excretion. There's a small portion of that that's actually metabolized in the kidneys and can cause direct kidney damage. So NAPQ can actually cause direct damage to the kidneys as well. And incidentally, I've seen it working in the poison center for the entire state of Georgia for 2 years. Once or twice I've seen massive Tylenol overdoses where people come in with like the Costco super giant Tylenol jars and they eat the whole thing. Like they're sitting there with a spoon for like half an hour just getting this Tylenol in them. And before you can even have Tylenol toxicity, that Tylenol can metabolize into oxaproline, which is a pretty significant acid, and it can also cause mitochondrial stunning, which causes a lactic acidosis. So if somebody comes in and they say, I just took my Tylenol 3 hours ago, and they're really acidotic, they're really sick, that could be an indication of a massive overdose. And it's not NAPQ causing the harm, it's actually the Tylenol itself and its initial metabolites causing mitochondrial stunning, and those patients, they're gonna die, and not much you're gonna do about it. Incidentally, immune-related cytopenias can be seen in these really sick patients. So what do you do? If a patient comes in, they say, I was at the bottom of the ambulance bay, I just took a whole bottle of Tylenol. They're in D40. They literally just walked in the door, they're still eating it as they come in. What labs do you order? And actually they might be sitting on the bed, the nurse is doing their vitals, they're like popping Tylenol, talking to the nurse. What labs do you order right off the bat?
Blood sugar.
Blood sugar, all right, I like it. Acute charcoal level, I like it. If we don't have acute charcoal levels, you can just empirically treat. Good. Do we get a Tylenol level? They're
No.
So it's meaningless. Before 4 hours, we don't know what to make of those levels. So you do not have to get a Tylenol level before 4 hours. But again, in a patient that comes in at or after 4 hours, the labs that we talked about already, the CBC, the CMP, the serum drug screen, which includes Tylenol and aspirin, plus minus coagulation studies. If the patient is hemodynamically unstable, if they're sick, if they already have right upper quadrant pain, you're going to want to be a little bit more aggressive with the labs.
Usually for the aspirin and TCA.
Can't hear what you're saying.
Aspirin and TCA levels earlier than that, or can
You can, absolutely. I mean, there's no indication not to, but at the same time, there's really no need to do 2 blood draws if you don't have to. In a hemodynamically stable patient who you are confident took it relatively recently, just get the 1 blood draw at 4 hours, easy peasy.
Is there any value to getting like baseline liver function tests, stuff like this? You can.
It's not going to change. It's really not going to change in the 4 hours that you wait. And truly, by the time they get in, they get triaged, you see them. It's already 2 hours. You put in the order, so it's not particularly helpful. On a case-by-case basis, there might be some incidences where you're going to want to do that.
It makes sense. Like either way, you're treating off the Tylenol.
Yeah, and you get labs at 2 hours, and then 2 hours later, you get more labs. It's not really going to change much.
How fast does it pop up if it's like after 2 hours?
So if somebody comes in and they're one of our frequent flyers, and you don't really think they took Tylenol, and they said, I took Tylenol half an hour ago. If you got a level and it was 0, then you can be confident that they did not take Tylenol. Within about a half an hour, if there is Tylenol in their belly, the Tylenol will start showing up in their serum. Very few cases where you're going to utilize that information, but if they deny taking anything and their only access to the pills was a half an hour ago, if you get a level, within about a half an hour, you're going to see something. So essentially, by the time the patient is triaged and you put the order in and they get the labs, if it's 0, it's 0. But you're probably going to want to wait for the 4 hour level anyway.
After episode heard 12 hours, I think beyond 12 hours you don't necessarily want to test, and then beyond 24 hours you don't want to necessarily, you don't have to treat. Is that correct?
We'll talk about it in a second. We're absolutely gonna get there. So when you get your 4 hour level, what is the first thing you do? You have a 4 hour level, it's 42. What do you do? stat Google consultation. And to this day, I still Google any nomogram that's available is available, just whichever one you have. So this is the Rumac nomogram. This has saved many, many lives and many, many healthcare dollars. So essentially, when you have a level, your best guess at the time post ingestion is down here, and you always want to err on the side of caution. So if you're not sure if it was 4 or 5 hours ago they took it, assume it was 5 hours ago. If you're not sure if it was 12 or 20 hours ago, assume it was 20 hours ago, because you do not want to miss a Tylenol. The difference between giving NAC and not giving NAC, a night in the hospital, but if you miss a Tylenol and you do not treat, that patient, it's too late at that point. Like 24 hours later, they come back, they're in fulminant hepatic failure. Like, sorry guys, I didn't spend 2,000 healthcare dollars on you, and now you need a new liver. So this is a safety line, this little dotted line up here. Anything below this dotted line is thought less than a 1% chance of having liver toxicity. So at 4 hours, if you are below 200 micrograms per deciliter, which is the units that we have here at Albany Med, and make sure you're using the correct units. If it's telling you that 20 is a toxic level, then you're probably using the wrong units. So anything below 200 is safe. Less than a 1% chance these patients are going to get sick, but that 1% chance is probably a too high of a chance. So in the United States, we actually use the 150 line. So at 4 hours, anything below 150, you don't have to treat, as long as you're confident that you're plotting it correctly on the graph. The half-life is about 4 hours. So at 8 hours, it's going to be 75. At 12 hours, it's going to be in the 30 range. So you get a level, and you get the level, it's 100. It's a meaningless number unless you know when they ingested it. So if they ingested it 4 hours ago and we're confident, you're good. You're below the treatment line. You don't have to do anything. If they ingested it 8 hours ago, you're right at the treatment line. You definitely have to treat these patients. And if you're not sure, say the last time the person was normal was 20 hours ago. Last boyfriend left 20 hours ago, and they came back just now, and you're altered. The girlfriend is altered, or whoever's altered. She could have taken it 4 hours ago, and she's going to be fine. She could just be drunk or what have you. She could have taken it 8 hours ago, and she's kind of borderline, but we're still going to treat her. Or maybe she took it right after she left, and this patient's in a lot of trouble. So when you're not sure, just assume worst case scenario. Just like everything else, half-lives and time to peak can be increased in overdose. How do we treat them? If they came in in the first hour to 2 hours, Andy's absolutely correct. I don't think I've ever called you Andy before. Bachman was absolutely correct. Charcoal. Charcoal, any toxin, as long as it absorbs to charcoal, as long as they don't have altered mental status, as long as they're protecting their airway within the first hour to 2 hours, give some charcoal. And I'm a big proponent of punitive charcoal. Like if you're like, I'm not sure that this patient actually took enough. It's not a pleasant thing to get, and it doesn't taste bad. It's just like this really chalky thing. So all toxicologists have tasted charcoal during their toxicology fellowships. If you are not sure, there is almost no harm to charcoal in an awake, alert patient maintaining their airway. Causes a little diarrhea. Don't want to give it to somebody who has a history or has potential for obstruction. So charcoal, absolutely give charcoal. And then what we said before, acetylcysteine. And there's 2 formulations of acetylcysteine. Do not be the resident that accidentally puts somebody on the inhaled, nebulized mucomist that is used for cystic fibrosis patients. That is not going to help with their Tylenol overdose. So there's oral and IV, and as you get further down the line, if they have hepatic failure, you do the things you do for coagulopathies, FFP, vitamin K. Liver dialysis is a thing. It's it's not very common, it's not very helpful, but in a few select patients, I think they do it at Mount Sinai, I think they do it in Boston, I don't think we're close to doing it here. It's really expensive and it's not particularly effective, but occasionally it can be a bridge to transplant in some patients. And lastly, organ transplants. So how does Mucomist work? So Mucomist essentially restores your glutathione. So when you make glutathione, it's a 3 amino acid little moiety, and cysteine is one of the less frequently and more difficult to absorb amino acids out there. So acetylcysteine is just a really easy way to increase your cysteine, which in turn increases your glutathione. Your body has such a high amount of glutathione in it that you can successfully protect against NAPQI for about 8 hours. Until 70% of your glutathione is used up, your body is going to be able to prevent NAPQI from binding onto your liver cells. So if you hit the patient really quickly with acetylcysteine, you're going to increase the glutathione, you're going to prevent the formation of NAPQI, and you're just going to create the glutathione-nated conjugate, and they're going to pee it out, and they're going to be fine. Over 99.99% of patients that present within 8 hours and get their first dose of N-acetylcysteine or NAC before the 8-hour mark have no signs of clinically significant liver toxicity. The real only exceptions to that rule are patients with the massive overdoses that have the mitochondrial stunning, which is very, very rare. Other exceptions to that rule are patients that we probably misclassified the time when they took it. So if you can get NAC in these patients before 8 hours, it really doesn't matter how much they took, you will not have clinically significant liver toxicity. This is one of Rumac's graphs that shows, hey look, no NAC, bad, NAC, good. A lot more to that graph, but that's really all you need to know. So NAC is like a toxicologist's best friend. If you ask a toxicologist, should I give NAC? The answer is nearly universally yes. If you ask a toxicologist, should you give benzos? The answer is nearly universally yes. But not only NAC not only works for Tylenol, it's also a really, really strong antioxidant. So in patients who have non-Tylenol associated liver failure, it can actually increase survivability in these patients. Not going to work for the chronic alcoholics, cirrhotics, but if somebody has some other liver insult for some other reason, try NAC. The worst that it can do is replete their glutathione. Oral or IV? Essentially, it doesn't really matter. The benefits to oral is that there's a huge first pass metabolism, so you drink the NAC and it goes directly into your liver. That's awesome. It gets there really quickly, as opposed to an IV formulation where it redistributes through your entire body. Only a small portion gets into your liver initially. The oral is going to be you have to drink this smells like rotten eggs solution every 4 hours for 72 hours. Suicidal patients are not the most compliant patients when it comes to taking medications, and they're also not necessarily going to want to be drinking this every 4 hours. They're going to be in the hospital for a minimum of 72 hours when you choose an oral course. So if the patient has other reasons to be in the hospital for 72 hours, or if they're particularly compliant, they have really terrible IV access, you can choose the oral course. The IV course is a little bit more expensive, but what you use in the front end and expense of the medication itself, you save in the back end that they only have to be in the hospital for theoretically 21 hours, depending on what their LFTs do. If their LFTs bump, if they start going into liver failure, you're going to want to continue these medications for longer.
But you can put oral NAC or charcoal down an NG tube.
You can. I don't know if that's a fight that I want to fight. But if you want to, absolutely, you can stick it down an NG tube. But it's really hard to prevent this. So either way. The big issue with IV NAC, anaphylactoid reactions are not incredibly rare. IV NAC can cause an anaphylactoid reaction. You treat it just like any other anaphylactoid reaction. You stop the IV. You give them the appropriate medications depending on their symptoms, you can actually switch them over to oral N-acetylcysteine. In that case, I would probably fight the fight and get an NG tube in those patients. And I think I already talked about this. Greater than 200 mg per kg per day for pediatric patients is when you have to worry. Another Tylenol fun fact, so Tylenol is absolutely lethal to snakes. So in Guam, they're overrun with these brown tree snakes. And so I actually read about this on like Wikipedia years ago. And what they do is they stuff mice with Tylenol and then they drop them from helicopters and the snakes eat the mice. And I'm reading this, I'm like, no, Wikipedia, they don't do that. I imagine somebody out there is trying to trick me. And no, it's actually true. They throw dead mice filled with Tylenol out through the streets of Guam. So a couple of cases, and I guess I probably need to speed this up because I'm supposed to talk about aspirin too. As you can tell, I love Tylenol. It's like the easiest thing, but it's really, really complicated at the same time. So you get a patient, and this is a 36-year-old male. He's fine, but he's been taking 2 tabs of extra strength Tylenol, so a gram of Tylenol, and 2 to 3 of his buddies Percocet every 4 hours for 4 days for pain. Toxic, not toxic? Yeah, probably toxic. If you did some math, you'd realize that's pretty gosh darn close to being toxic, but he's in D45, so you get what every patient in D45 gets. And his last ingestion was definitely 12 hours ago. Tylenol level's 21. Cool, right? The nurse just ordered a Tylenol level for you. Tylenol level's 21. Can he get discharged with?
Well, for that, yes.
So let's see, 12 hours post-ingestion, 21, well below the treatment line. So maybe X-ray, neomobilizer, DC? No, we can't do that because he's already had the toxins. It's been going on for 4 days. The Rumac nomogram doesn't apply to chronic ingestions because although he's not acutely toxic from his Tylenol, he's got a ton of NACI in his system and it's already causing LFT elevations. In this same patient, if he didn't have LFT elevations, what would we think? Probably somebody I would want to repeat labs on a little while versus just pull the trigger. If he's been taking a lot of Tylenol, you want to be very, very careful with these patients. So essentially, if he had a Tylenol level of 0 and normal LFTs, we're good to go. If he has an elevation of either one, you have to be very, very careful about discharging that patient, and most of the time I would just err on the side of treating because it'd be really terrible if we took a patient with knee pain who was just trying to feel better, and in 3 days he came back from a brain bleed because he's so in fulminant liver failure.
Molly, even if he doesn't meet the 10 gram to 16 gram max dose, let's bump.
So absolutely, bump in the LFTs unequivocally. If he has a history of cirrhosis or you have documentation that he had old LFT bumps, you could on a case-by-case basis choose not to treat that. But if you're not sure and the LFTs are even mildly elevated, you're just going to want to go ahead and treat because this is a very, very easy treatment for a very, very severe disease. Okay, so this patient, 46-year-old female, took a handful of Tylenol at the bottom of the ambulance bay. The nurse grabs you a Tylenol level. It's 267. She has normal LFTs. Treat, don't treat. Absolutely. Repeat it at 4 hours. So her 4-hour level turned out to be 96. It's in the no treatment line. So she's made her way over. She's going to make her way over to CDPC. But you can see that this line, it is completely blank. In the 0 to 4 hours, we have no idea how to interpret that information. And I've had patients who, within an hour, 2 hours, are in the 200-300 range that are going to normalize, and you don't actually need to treat them.
Do you ever get like initial labs that don't have a bump in AST and ALT and do 5 hours later, but they're below the nomogram treatment line?
Very, very rarely. So if your nomogram is accurate and they are below the treatment level, then they will not have a bump in LFTs. However, if you do get a bump in LFTs, it's because you were inaccurate somehow, and that's why you have to err on the side of caution. And other instances would be if they're taking either an extended release preparation that we're going to talk about right now. So there's Tylenol arthritis is extended release. Tylenol PM tends to be extended release. So these patients, you might want to get a 4-hour level, but if you're sure they took an extended release preparation, get an 8-hour level too. And like that's gonna it blew. I think I was working with Tim Barcombe, and we got like an 8-hour level of Tylenol, and he's like, no, we're not doing that. But the patient had an extended release formulation, and there have been case reports of it crossing a nomogram. So that's another reason why it's important to know specifically what medication that they took. And if either breaks the nomogram, you got to treat them in that case. Unknown time of ingestion, you want to go with the worst case scenario. So if it could have been 4 hours, but it could have been 20, just assume it's 20. And here's the numbers. I think this answers your question, Erica. So what I was talking to up until this point is an acute ingestion. When we're talking about chronic ingestions, the numbers change. So for adults, if they're taking 10 grams over a single 24-hour period, 6 grams per 24-hour period for longer than 24 hours. So if they're taking 6 grams a day, it's not really a lot. It's just two extra doses over the course of the day. Those are the patients you really have to be worried about. And the numbers for pediatric patients, 200 milligrams per kilogram, 150, and then 100 for 24 hours, 2 days, and 3 days. These are numbers that you can always look up. You can always call the poison center. And again, patients who are glutathione depleted are going to have lower ability to tolerate those doses. And I think last but not least in terms of Tylenol, and I guess we're going to probably end just on Tylenol today, is sick patients. If you have a patient transferred to us, or as an attending, you have a patient, a small outside hospital that wants to transfer to your ICU, if the patient comes in hepatic failure, already has bumped LFTs, they're already showing signs of coagulopathy, you don't want to accept patients that are starting to meet the King's College criteria. You want those patients to go to a transplant center if possible. So signs that their liver is actually failing, besides just elevated LFTs. You can have LFTs in the 10,000s and your liver can still be functioning properly. You have damage, but the liver is still making enzymes. But when you know your liver is not doing what it needs to do, you're acidotic because you're not using your Krebs cycle. You're not recycling the lactic acid back into glucose. So if you're acidotic, if you're starting to show signs of kidney failure, if you're starting to show signs of elevation in your INR or your encephalopathic, you do not want those patients to get transferred to you. You want them to get transferred to a transplant center. So if you have a particularly sick patient, these would be patients that we would transfer out of Albany Med. In addition, adding to the King's College criteria, and you can go on MedCalc, King's College criteria, and just enter your numbers in, and it can give you a prognostic that the chances that your patient is going to need a liver transplant, or the chances. And by need a liver transplant, if you don't get the liver transplant, you're going to die. So when I say need a liver transplant, it really means the chances that your patient's going to die if he doesn't get one. Elevated lactate, again, that goes along with the acidosis. And then serum phosphate concentration. Nobody ever gets this, but this is one of my favorite labs for prognostic indicators because your body needs phosphate in order to regenerate your liver. So if you don't have any phosphate, it means your body's utilizing your phosphate to regenerate your liver, and that's a huge and wonderful prognostic indicator. I don't think you guys care about orthotopic liver transplantation, but it's a thing. You can give a small amount. You can give somebody a small little piece of liver and let that liver do the job of the liver and give them all their anti-rejection medications until their native liver heals, and then just stop the rejection medications, and then your transplanted liver dies, but you have your regular liver still. How does the donor do? I mean, it's a major surgery. Somebody's cutting into you and taking part of your liver, but fine. You only need half of your liver. And the donor oftentimes will have their liver regenerated to begin with. So liver for everyone. There's a million things I could talk about on salicylates, but I talked too much about Tylenol.
One comment. Not surprisingly, the charge nurses at CDPC are not as knowledgeable about acetaminophen toxicity as Dr. Boyd. And
Thank you.
will sometimes tell you to do things that are not the right thing. So you have a 6-hour non-toxic acetaminophen level, and they want another acetaminophen level to quote make sure it's going down. And no. So do the right thing. Talk to your attending if CDPC is giving you pushback about asking you to do things that are not medically appropriate, but don't just say, okay, I'll do that, and then do things that don't make sense because the charge nurse at CDPC is not, in fact, a toxicologist, although they might sometimes try to play along.
And if it's a big deal, always call the poison center for any of these cases. Call the poison center because sometimes there's just cases where there's just that little thing that we're like, you know what? Let's do this. Let's check this. Let's treat or not. Like always do this with your poison center or your toxicologist, whoever you have available. When CDPC gives you pushback for tox issues, call the poison center or the toxicologist on call. The poison center says, I need to do this. A triage nurse at CDPC should not override the poison center. And if, you know what, you can really get this patient out, you really need to get this patient out, and you don't have time to convince the charge nurse at CDPC, your attending doesn't have time to spend 20 minutes on the phone discussing with them why you're not going to send a serum Ativan level on this patient who's hemodynamically stable, us toxicologists can do it for you. I mean, I can do that from home. They can say, I want a serum Ativan level. I can say, no. We oftentimes will have the time to have that conversation with them. And when you really start using big words, it can convince people to do what you say just so you shut up.
Another reason to call the poison center is to keep their numbers up. We like them. We like them to be funded. We like them to demonstrate their utility in the world, and we appreciate their input most of the time.
Yeah.
My understanding is that they want to call on all of this stuff anyway because they use it to track data over time, even if you know what you're doing and you're treating them
Absolutely. If you look at our poison center data on like heroin overdoses, you would think that nobody overdoses on heroin. But theoretically, it's an overdose, right? So people should be calling the poison center, but we know how to treat heroin, except in the few cases where something happens that we're not used to. So they do absolutely use it to track data. If you can call and report heroin overdoses, again, the poison center gets more funding. They track things. But for Tylenol, even if you're consulting the toxicology service, either you guys or the toxicology resident on call or the attending toxicologist is going to notify the poison center. And we all oftentimes work together. And if you're not sure, you're like, you know what, I have a patient and this is going on, call the poison center and be like, hey, is this something appropriate for a tox consult? If you're not sure if it's worth a tox consult, the poison center can absolutely help guide you. Or call one of us, the attending on call, and be like, hey, is this something that we need to think more about, or is it something that I can just treat and street? Questions, comments, concerns? Everything you ever needed to know about Tylenol? We're good? All right. Thanks, guys. I'm going to leave this to Greg Wu because I don't know how to use this window.
Just a reminder, everyone, don't fill out your feedback forms. I think last time there was one from last week.
And if you guys are confused on how to fill out the feedback forms, just put Molly Boyd, excellent. That's all.
5 stars.